Okay, so hello everyone who is here and those who will watch at home. So what we're going to talk about now is abnormal uterine bleeding. So the bulk of what we discussed already in this lecture series has been about the pregnant patient. This is now going to transition over to the non-pregnant patient. The majority, if not all of the patient complaints and pathology that you see in the non-pregnant patient in what is referred to as gynecology is surrounding some sort of complaint of bleeding, some sort of bleeding disorder. And when I say bleeding disorder, I don't mean an intrinsic problem with the hematologic system. I'm talking about strictly from a gynecological standpoint. So this lecture is going to be pretty comprehensive in all you need to know regarding abnormal uterine bleeding in a non-pregnant patient. And more importantly, what I will explain is the physiology and the why of all of these conditions. Understanding why these things are happening will be your greatest signpost to the actual underlying pathology, and it'll help you when you see our patients on your clinical modules in addition to your test questions, okay? So to start, it's important to realize that any sort of bleeding complaint that is in the field of gynecology is going to be in relation to the patient's menstrual cycle, okay? Um, and that's why we're always in clinic asking for a patient's last menstrual period. And the reason for that is because it'll give you a clue as to part, what visceral structure is being affected, causing the bleeding disorder. And I'll explain that as we go. So the menstrual cycle is generally 5 days in length, and it lasts between 21 days and 35 days in terms of its entire cycle, but the actual bleeding happens for 5 days. There are a bunch of terms that have been traditionally used, um, such as menorrhagia, metrorrhagia, polymenorrhea, and oligomenorrhea, but there's been a shift from ACOG to really keep the language a bit more plain, so there's understanding across specialties, but more than that, so the patient also understands. If you, what an error is that using terms like menorrhagia, metrorrhagia, patients are not really going to understand. That being said, in foundational materials or even just older nomenclature sometimes is used, so it's important to be aware of what these things mean. So menorrhagia means heavy menstrual bleeding, even though this term is favored. Classically, it was defined as something greater than 80 mLs, but because we're not exactly sitting and measuring these things, uh, in addition to the fact that all patients are different, the patient's perception of how heavy or not heavy their periods are is the most important thing, because objectively, by this definition, a woman may have heavy periods, but that's normal for her. If she presents to you and says, hey, look, my periods have been heavy, that might mean that her baseline has changed. So a change in patient status or baseline in reference to the menstrual period is very important. So this is always something to keep in mind. um, Metrorrhagia is bleeding between periods. Um, so they have their cycle, they have their 5 days, and then they're having bleeding in between that. Usually that's what a patient will say is spotting, right? Polymenorrhea means that it happens more often than every 21 days, and oligomenorrhea happens less frequently than every 35 days. You're not really going to hear these terms as much. Menorrhagia you may hear because it's heavy menstrual bleeding is usually the principal problem, but usually you'll hear heavy menstrual bleeding. Intermenstrual bleeding is sometimes the term that you'll use, which is spotting, which is really metrorrhagia. Um, Amenorrhea is a term that you will hear, and that's actually still standard. Amenorrhea meaning that you don't have a period at all. Okay. Um, Now, the reason why I mentioned the menstrual cycle is because you really have only two forks in this road to figure out why a patient may have abnormal bleeding, okay? For our purposes, we're just going to keep this term. And this is what I mentioned before in terms of terms that are actually used. This comes from the ACOG Practice Bulletin, as of most of what I speak about. And in terms of things you'll actually see written down, AUB is an acceptable definition. HMB, IMB, that's not really used. Okay, just FYI. But these terms, heavy menstrual bleeding and intramenstrual bleeding, are used. And I'm not one for mnemonics, but this comes from ACOG, so it's relevant. This palm coin you might have here, but you basically have structural and non-structural causes. And really, the ones that are most important are your ovulatory dysfunction, and then, of course, your structural causes. Coagulopathy, yes, but that will be that's sort of an exclusionary diagnosis once you've ruled these two out. And also that then involves correcting the underlying coagulopathy. We mentioned the menstrual cycle because an important concept here is that if you have regular periods and the patient has always had regular periods, you don't have ovulatory dysfunction, because ovulatory dysfunction is driven by what structure? It's driven by the ovaries, okay? The ovaries are, when functioning properly, will give you your timing of your menstrual cycle, because they respond to the hormones that are released from the anterior pituitary and then in the cascade, as I'll explain. If your ovaries are normal, your timing, your ovulatory, your cycle will be normal. If the patient has abnormal periods, anyway, well, that's a different story, but that's a bit more of a nuance. So a structural cause is due that there's a problem with what? The uterus itself. Is something structurally abnormal about the uterus, okay? So we mentioned the menstrual cycle because if you have an otherwise normal uterus, but you're having ovulatory dysfunction, you'll have bleeding, okay? Usually it could be heavy or instrumental or both in the way that I'll explain. But at the very least, if you have regular periods, you're not considering ovulatory dysfunction because your ovulation, your cycling is normal. And then obviously you want to check something for the uterus. But that is initially where this pathway begins. You figure out the timing of the menstrual cycle. Moving forward, then you have to figure out whether the bleeding is due to a non-structural cause or a structural cause. And the way that you do that is through the variety of tests that you will order in addition to your physical exam. Okay. We'll get into specifics, but just to briefly mention, so you have an idea of these concepts and reinforcement is helpful. A structural cause, what sort of tests do you figure you need to order to see if there's something structurally abnormal with the uterus? You have to have some sort of imaging, right? So you're going to order. To start a pelvic ultrasound. That's where you start with this to see for structural causes. And structural causes, you're looking for things like endometrial polyps, leiomyomas called fibroids, adenomyosis, which is endometriosis, but when it's localized to the myometrium, because the endometrial tissue is the cavitary cells, which respond to the menstrual cycle. The myometrium is just the muscle of the uterus. When that grows into the myometrium, then you have that sort of cycling happening within the wall, the muscle of the uterus, the uterine corpus, and that is causes pain. And there's certain findings on imaging uh, that um, will portend that diagnosis. One of them being a symmetrically enlarged uterus that's larger um, than a non-pregnant uterus should be, which is usually greater than an 8-week size, we say. But that's an example there. And then also about malignancy and hyperplasia, which can cause bleeding and is a structural cause, you will also get an indication with on imaging, but you need to go further with a tissue sample. Excuse me. Just going to pause this. So malignancy and hyperplasia, while we could identify this on imaging, it also is important to have a tissue sample to confirm. And I'll explain all of that. So those are your structural causes, but in tandem with ordering your imaging, you're also going to evaluate if you have a coagulopathy or ovulatory dysfunction as well with certain tests. But these are all laboratory tests. Okay, so they're labs, which I'll explain. But at least you know your fork in the road. You're getting imaging to review some structural cause, some labs to do these, and this is your initial workup with suspicion for what may be involved. So let's discuss first structural abnormalities. So the most common structural abnormality that you'll encounter are uterine leiomyomas. They're also called fibroids because of like the fibrous appearance of these, of how they were originally described, the tumors themselves. So it's important to know that this is the most common kind of abnormal uterine bleeding, and it can be heavy or prolonged menstrual bleeding. And this can result in anemia. A lot of times our patients, if they don't follow up, they end up getting dizzy or something like that, and they end up in the ER and then needing transfusion due to their fibroid uterus here. It's important to know that like these are benign tumors is how they work. And you want to think of them like that, okay? You can see in this image, which is a nice stylized image of a sagittal cut of the uterus, that they're smooth muscle tumors here. So as such, they can recruit their own blood supply, and they're very vascular, and they can cause abnormal bleeding of the uterus, mainly because they can't contract, but also of a couple of other insults to the structure of the uterus here. It's a very common condition. Even most lay people have heard of it. Some studies report it happens. The presence of fibroids are about 70% of white women and up to 80% of black women by the age of 50 years. This doesn't necessarily mean that you're going to have a massively enlarged uterus because of fibroids, but this is just the incidence of it in general. So when we describe leiomyomas, there's a categorization of where they're located, and where they're located also has to do with their symptoms. So even before you order your ultrasound, you want to be the clinical symptoms will direct you into what may be happening. And so you have, in the uterus, you have the myometrium, which is the actual lining. There's an outer layer of the uterus. There's a thinner layer called the serosa. And then you have your endometrium, which is where the uterus can either accommodate a pregnancy or shed the lining during a menstrual cycle. So subserosal means that it's just below this outer layer. Submucosal means it's within this, it is more on the inner layer. Intramural is within more of the center. And then pedunculated, sometimes these things can have a stalk, either pedunculated like this on the outside. So pedunculated subserosal would look like that, and then a pedunculated submucus is on the inside, okay? Um, there's not really a medical treatment that is long-term, so these are still managed surgically, and this is the most common indication for a hysterectomy. Um, there is the Federation of International Gynecologists and Obstetricians has a sub-classification system that you definitely don't need to memorize, but I mention it only to highlight the different types of fibroids that you can have. This is an example of actually of a pedunculated one. So you have 0 is a pedunculated intercavitary one. Okay. Um, ones that fibroids that are more in the cavity are going to have more bleeding associated with them. Okay, as opposed to say 6, which is your subserosal, where it's mainly on the outside, or even your pedunculated 7, that is going to present with more bulk symptoms like early satiety or urinary frequency. So you may have a patient who has a bulky fibroid uterus, mainly with fibroids like 6 and 7, who they won't even have any bleeding, but they have a lot of pelvic pain and they have bloating and urinary frequency, and it's very bothersome because they have all that pressure. Okay, sometimes you have a patient who has all of these, so they're bleeding, they're cramping, and they're just miserable. Um, or you have patients who simply just have bleeding, and the uterus is not particularly enlarged. It's just that you have many myomas, say, in the cavity, which is how you have to think about where the fibroids may be. Of course, you're going to get your imaging and things like that, but it all adds to the clinical picture. And also, it depends on what you're going to do about it, as we'll explain with the treatments. But you also can have something called leiomyomas are not a they're not unique to the uterus. They can actually be anywhere. I had a patient who she had like a chest mass. She was an oncology patient, and they ended up resecting it, and it came back that it was a leiomyoma. It was a fibroid. So we were like, oh, she has fibroids. But it's unique because they're very common in the myometrium. But just keep that in mind. So basically, 8 means it shows that they could be anywhere else. You could have them in the cervix. Um, you can have them actually in the broad ligament just on its own, where it's not even related to the myometrium. So sometimes those situations happen, which is a bit more complicated. But understand first that the fibers can have different locations, and then of course they can occupy all many locations. Like this is what the 2 to 5 is showing you, right? It could be something it goes into the cavity and goes all the way out to the subserosal space. So when you have a bunch of larger fibroids like that, that can cause a lot of symptoms in the patient, and it matters on how you treat it. Okay, so and this is a visual way to actually take a look at what it is. And actually, this is pretty good, even the way that it was colored, because this is actually what it looks like. It's a smooth muscle tumor, but it's vascular, so sometimes it might have area necrosis, like you see here. And then some of them are on little stalks here as well. So we'll get into treatment, but this is a very common complaint. You will most certainly hear something about this on your clinical modules, and most surgical procedures in gynecology are focused around management of leiomyomas, as I'll describe. You also have the most common structural abnormality is called an endometrial polyp here. So you may know on other rotations what polyps are. They're hyperplastic growths of something, right? A lot of times when you're on your surgery or medicine rotations, you'll deal with colonoscopies and things, and there'll be colonic polyps, right? Polyps usually are indicative of they could either be benign or they can be associated with a carcinoma. For us, endometrial polyps are by and large usually benign. What you want to start to think in gynecology about things not being benign when you reach when a patient is postmenopausal. Okay, when we discuss the menstrual cycle, I'll explain why that is. But um, postmenopausal patients is where you want to have a suspicion for endometrial cancer and malignancy, because having endometrial polyps and leiomyomas are responsive to estrogen. And if you're having regular periods and you're having ovarian function, you should have estrogen stimulation. If you don't have that and you're still receiving estrogen stimulation and growth, well, there may be a reason why that is, and that reason is a concern for carcinoma. But in the patient who is premenopausal, things like polyps and fibroids are estrogen responsive, and they're not um, usually concerning for endometrial cancer. Okay, but we'll discuss endometrial hyperplasia at the tail end of this lecture. Endometrial polyps are they're hyperplastic growths of the endometrium. Okay, so by definition, they cannot exist outside of the uterine cavity. That's different from fibroids, right? Because fibroids can be anywhere because they're smooth muscle tumors, right? Uh, Endometrial polyps are hyperplastic growths of the endometrium itself, and they have increased vascularity. So the reason why that they are problematic, because they can cause cramping and bleeding. What ends up happening is that uh, I'll get back to this ultrasound images, but the polyp will develop in the endometrium, and then it will hang down into the cavity because it has increased vascularity. Kind of what these images. Well, this is a hysteroscopic image. Hysteroscopy is when we put a camera into the uterus through the vagina, through the uterus here, and take a look. And this is what it looks like. A polyp. You can see that it's a growth on the endometrial lining. Okay, but you can appreciate there's increased vascularity here, so it can bleed. But the reason why um, symptomatic polyps happen is because this hanging down, the polyp hanging down into the cavity, that makes the uterine cavity think that there's something abnormal in the space, because as I've said before, the uterus has two jobs. It can either accommodate a pregnancy, or it contracts to push out things that don't belong. So it tries to push out this fibroid, but I mean this polyp, but because it's attached, it goes nowhere and it gets disrupted. So you have bleeding and then also cramping because the uterus is literally contracting. Okay. On ultrasound, you see something that presents as a thickened endometrium. Okay. Um, Usually, a thickened endometrium is not a term that's used in the premenopausal patient, because um, that sometimes to have a tissue that's developed is normal. But here you have, this is measuring about 1.2 centimeters, 1.3 centimeters if you round it from here to here. So that's abnormal. Usually like 5 millimeters or something greater than that is what we would call thickened. Now, in a postmenopausal patient, it's a bit different. But when we talk about diagnosis, we'll explain that. But on ultrasound, you see a thickened endometrium, and then it'll describe on the ultrasound it's an area with increased vascularity. That's how an endometrial polyp is defined. And this is literally what it looks like. You can have endometrial polyps and you may not have symptoms, right? Because you could have a bunch of small ones here, and their presence is not a problem, and it doesn't actually increase your risk for endometrial cancer or anything like that. But when they become symptomatic, um, a patient will present with complaints, and then with bleeding complaints, and then that's something you have to evaluate. But like I said, you go back to the beginning, you're going to order your imaging to make sure you're ruling out things like polyps and leiomyomas. Um, Clinically, endometrial polyps usually present more with spotting, uh, but when you have a bunch of them and they're large, it can present with heavy menstrual bleeding, heavier bleeding than just spotting. Okay, so you have to rule that out. Those are the main structural abnormalities that you need to know. And frankly, you your first run is to get an ultrasound and see what it shows. And that will really direct you. To manage structural abnormalities is, like I mentioned, primarily surgically. But there are certain medicines that you can use, but they're not going to provide the long-term treatment that is going to be most beneficial. But there is a role, and I'll explain. So let's talk about that first, because it's a little less obvious. Your options for medical therapy are really three. You have your levonorgestrel IUD, trade name Mirena, but there's actually a bunch of others like Skyla and Liletta these days. You have your GnRH agonists, which is mainly brand name Lupron. Now keep in mind, agonists and antagonists. So GnRH agonists are a class of medicine that was always used. Now there are other medicines on the market for the management of endometriosis, for example, that are GnRH, excuse me, antagonists. Okay, GnRH antagonists are actually used in fields like urology for prostate cancer as well, but this is something that's fairly new, so don't get yourself confused. And I'll explain this, so just keep that on your radar. And then you have antifibrinolytic agents, which is mainly tranexamic acid, and the trade name for what we use in gynecology is Lysteta, and I'll explain. So levonorgestrel IUD. I'll explain more about IUDs when we get into our ovulatory dysfunction section, because that's primarily where they're used. But basically, IUDs is something that most people have heard. IUD stands for intrauterine device. And it's a T-shaped device. All of them more or less have the same structure, and they have a rod where their active ingredient is. So for Mirena, it's 52 milligrams of levonorgestrel, which is progesterone. Okay. There are different forms of progesterone, as I'll explain. But just know that when progesterone is the medicine being used. And when we discuss the menstrual cycle soon, you'll know why progesterone is used for heavy menstrual bleeding. But so there are no randomized trials looking for the use of this in heavy menstrual bleeding and as it relates to uterine leiomyomas, just to start. But there are studies that show that it can help, right? It reduces the volume of bleeding and increases the endpoints being that it reduces the uterine volume and bleeding, and also increases the patient's H&H. Okay. If you have intercavitary leiomyomas, that's a pretty strong relative contraindication, because obviously if you're trying to put a IUD in this cavity that's all distorted, it's not going to work. Okay. So that's why the location does matter. If you have a bunch of fibroids out here, but none in the cavity, then this becomes an option for you. Usually people will give it a try if surgical management is not desired by the patient, okay? So that's an option. GnRH agonists are probably the most effective therapy in relation to uterine myoma, but there's a catch. The catch is that they're effective only in as much as they basically induce menopause, and they do it in the following way. The GnRH agonist, the way that it works is mainly due to its effect on the hypothalamus. So what it will do is it will stimulate GnRH, and that will act on the anterior pituitary, right? And we're talking about the anterior pituitary when we're talking about the gynecologic patient, because what is the posterior pituitary responsible for that we care about in the field of obstetrics and gynecology? Posterior pituitary stores oxytocin, right? And remember that because sometimes they like to ask you that. It's made in the hypothalamus, but it's stored in the posterior pituitary, okay? The anterior pituitary actually makes its own stuff. So this will, the anterior pituitary then is responsible for making your FSH. And then that will respond to the ovary, and then that's where estrogen will happen, etc. But when you have your agonist, what ends up happening is that while there is an initial bump in this response, because it's an agonist, prolonged exposure to the agonist creates a negative feedback loop to the anterior pituitary. So what's this diagram is showing you is that, okay? So that when you use the GnRH agonist, prolonged use will cause a downregulation of the GnRH receptors, and then that will lead to decreased FSH and actually causes hypoestrogenemia because it shuts down the ovary. And then that will deprive the patient's circulation of estrogen, and because your fibroids are responsive and dependent in some way on estrogen, they'll shrink. So that'll help resolve the symptoms. And also because you're not having periods anymore, because you basically put the patient into menopause by virtue of the fact that you shut this ovary down, they're not going to have bleeding. Okay? Most women develop amenorrhea. Okay? And then you get improvement of anemia. And the uterine size will decrease within three months. Okay? But putting somebody into menopause severely is not has its own problems. For example, you have significant symptomology. You know, you have everything that you suffer from with menopause, like hot flashes, sleep disturbances, myalgias, um, dryness, and even mood impairment, right? So sometimes these symptoms are worse. And more than that, uh, there are there are consequences to putting a patient into premature menopause. That's why we don't just remove all women's ovaries early on. Putting them in menopause has symptomologies like this, but also has implications in cardiovascular health and uh, bone health, like osteoporosis. You know, there was a large study that was performed that set precedent in that they were removing ovaries early on women to see if it was going to be beneficial for them from an ovarian cancer standpoint. It actually turned out that their overall mortality increased by all cause. So all cause mortality increased by removing ovaries early, which means that you're effectively shortening a woman's lifespan if you take her ovaries out too early. Okay, so this consequence, more than just a side effect issue, is a can be a potentially serious one. So what I'm trying to tell you is that while this works, it has to be um, used judiciously, and really what it's used for is for preoperative therapy. So if you have big, bulky fibroid uterus, you can give a 3-month course of Lupron, or even shorter, 1 month, not longer than 6 months, really. And that can shrink the fibroids. And then your surgery becomes a bit simpler, and also less risk of intraoperative bleeding. Okay, um, it's approved, FDA wise, for about 3 to 6 months prior to a leiomyoma-related surgery. Lupron is used for that, and also it's used in the management of complicated endometriosis. And what I mean by complicated is usually well, not usually, but endometriosis is similar to leiomyomas in that it's not localized to the uterus itself, or really even the pelvis. Okay, you can have peculiar situations like catamenial endometriosis, where it actually implants in the lung. This is an example of a pneumothorax caused by endometrial implants. When I was in residency, we had a patient who was in and out of the hospital because she had catamenial endometriosis, and she would present often with hemothorax due to um, her endometriosis in the lungs. And she would need a lot of VATS procedures and things like that. Even when she was clinically stable for surgery, the unfortunate truth is that even a bilateral salpingo oophorectomy, I mean, well, bilateral oophorectomy, okay, so take the ovaries, right? Um, there are risks, as I mentioned, to taking both ovaries, and she was in her early 40s at the time, but had been dealing with this since she was in her late 20s. Um, so there's consequences that from a long-term health, overall lifespan perspective. In addition to the fact is that it doesn't necessarily mean taking out the ovaries doesn't necessarily mean that this uh, situation will be mitigated, right? Because think about your disease process. Endometriosis is ectopic implantation of endometrial tissue, meaning that the endometrium will do what it does as long as it's stimulated by the right hormones. So you may not have an ovary that's producing estrogen, but where else is estrogen produced? It's produced in the peripheral adipose, right? That's where you make estrone by your enzyme aromatase. That's why some medicines, like cancer medicines, are aromatase inhibitors. Okay, so your adipose will do that, and it does it even if you're not morbidly obese, right? The only reason why we say morbidly obese women are at risk for that is because the more fat you got, the more adipose, you more aromatase, and the more peripheral conversion of the cholesterol pathway to estrone. Okay, and on that same topic, this is why morbidly obese women are at risk for endometrial cancer because they have this stimulation, this excess stimulation of estrogen as well. And as I'll get into in the ovulatory dysfunction part of this lecture, and speaking of the menstrual cycle with its hormones, unopposed estrogen is what drives the problem with ovulatory dysfunction, but it's also what drives endometrial hyperplasia and endometrial cancer. Unopposed estrogen. Unopposed meaning that there's no balance between estrogen and progesterone. So the presence of estrone in abundance throws off that balance, as I'll explain. But in cases of women who have endometriosis, not removing their ovaries is not going to necessarily solve the problem. So this is why GnRH agonists are used. And basically, they strike a balance between the symptomology of it and the symptomology of the actual endometriosis itself. So it's very difficult. Or myomectomy or stuff like that. I'll get into the surgical management. Just keep in mind that really this is not ever going to be the answer on a question, right? Very rarely. If they're going to ask about GnRH agonists and Lupron on your examination, is going to be primarily focused about the physiology of why it works. Okay, and why it works is because you have your stimulation, your persistent agonism is going to cause a negative feedback loop, which downregulates the receptors in the hypothalamus, and then that will lead to decreased secretion of the FSH by the anterior pituitary, and then that lack of FSH stimulation will then lead to a decrease in estrogen release, and then you essentially go into menopause. Okay. Now, the last class of medicines we'll speak about are the antifibrinolytic agents. So something that's been really popular in the field of obstetrics and gynecology is the use of tranexamic acid. Tranexamic acid is an antifibrinolytic, okay? So it works on the coagulation cascade. It's used in the treatment of idiopathic heavy menstrual bleeding, meaning that there's no reason identified. Um, it is FDA approved for heavy menstrual bleeding. And the reason why we bring it to the field of leiomyomas and structural abnormalities is because the trials that they used in order to get an approval for the treatment of heavy menstrual bleeding, 35% of those women had fibroids. Um, so they're kind of extrapolating it to that. A lot of times in obstetrics and gynecology, and really all research, you got to be careful because sometimes they'll approve something for one specific situational use, and then it's just widely applied to things that it may not apply to. But anecdotally, if you have a patient who has fibroids, you can, and she's having heavy menstrual bleeding, you can have this patient use tranexamic acid during those 5 days. Remember the 5 days that the cycle actually occurs, and that will lower the volume of bleeding and help with anemia. I know a lot of times that what I'll do is that if I have a patient that I'm preparing for a surgical procedure, um, uh, and in the meantime, either if she needs medical clearance or for whatever reason that there's not an immediate need for the surgery, which is usually the case, I say, all right, well, if when you get your cycle, take the 5-day course of Lisdeta, which is tranexamic acid, and that will help to make sure that you don't, your blood count is as high as it can be. So that can help as well. Also, it turns that if have uh, you have heavy menstrual bleeding, but you also, your the size and volume of the leiomyomas you have are perhaps not very large, but still you could have multiple smaller fibroids that can cause a uterus to have heavier bleeding. This is helpful. So it's not going to solve the fact that you have uterine leiomyomas, but it can help. Okay, and tranexamic acid is something good to be familiar with because it also has a role in postpartum hemorrhage too. It's not your first line in terms of the uterotonics and everything else that I described. It's not really part of that pathway. But if you have a postpartum hemorrhage that is particularly difficult to manage, or you can add that to your blood products as you transfuse. Or what some places will do is give it preoperatively in cases where you are suspecting a postpartum hemorrhage based upon certain risk factors, or even just to mitigate surgical blood loss at time of cesarean delivery. So it's a good medicine to become familiar. The way that it works is that it discourages this conversion from plasminogen to plasmin, which kicks off will stabilize the coagulation cascade. All right, it doesn't necessarily increase your risk for things like deep vein thrombosis and things. So that's why we use it in pregnancy. But it's generally avoided if there are significant risk factors other than things like the pregnancy and immobility, which is what we have to deal with in the obstetrical patient. So just to recap, and this is going to be recorded, so if you need to pause and review, perfectly fine. But options for medical therapy for structural abnormalities include levonorgestrel IUD, GnRH agonists, and Lisdeta, tranexamic acid. Okay. Levonorgestrel IUDs are a medicine you can try it and see how it goes. Okay, if it improves things, which it may, great, and then you can leave it. As I'll get into with the IUDs, progesterone IUDs can stay up to 5 years. Okay, GnRH agonists, very effective, high side effect profile, and they only have a temporary use, usually as preoperative treatment and selected uses in cases of endometriosis. Tranexamic acid, it's usually used as a 5-day course during the actual flow of the menstrual cycle to lower bleeding. This doesn't eliminate your cause, but it can help buy you some time. It's not a long-term solution. Now we can talk about surgical management, which is the definitive treatment for structural abnormalities, okay? So I'm going to just start with alternatives to hysterectomy because hysterectomy is ultimately your definitive treatment for abnormal bleeding secondary to leiomyomas. ACOG and the greater medical community kind of behooves you to provide patients with an alternative to hysterectomy before you um, choose that route. And that involves a consideration of why they are having bleeding. Because uh, sometimes someone's having bleeding, they say, "Oh, well, take the uterus out." That's not how a good gynecologist does things. Nor is it what uh, it's not the standard of care. Okay, a lot of times other specialties will approach us and say, "Oh, this patient's bleeding; she needs a hysterectomy," right? But that's not always appropriate based upon what the finding is, because you got to consider what the structural abnormality even is, right? If we have a bunch of leiomyomas that are causing bleeding that are in the cavity here, there's a way that we could address those cavitary myomas. It doesn't need to take out the whole structure. In addition, if you have an endometrial polyp that's causing your bleeding, well, you have to simply just remove your endometrial polyp, right? So that's the logic. So that being said, in relation to leiomyomas, all alternatives to hysterectomy allow the possibility of new lyomas to form. A lot of times your patients are going to say, if I do this, can they grow back? And the answer is invariably yes. Even if I remove every single one that I see, which is possible, that's not grandiose, um, they can come back. They're estrogen responsive, okay? Um, so they can grow new ones, or there may be smaller ones that are undetectable. So you can't promise that an alternative will remove it entirely. And that's often the reason why patients elect for hysterectomy, because they're like, listen, I'm done, and I don't want the possibility of them growing back. But if the strategy of your alternatives of hysterectomy, though, is to be in line with the goals of the patient. If you have a very young patient, and by very young, I mean, say, in your 30s, that it behooves you to try to have an alternative. So you have to plan in accordance to the goals of the patient, okay? So for example, so if a patient is in her 30s and she has a myomatous uterus that's bothersome, and sometimes you'll have a patient who has quite a large fibroid uterus um, in her 30s, and she desires future fertility, for example. That surgery that you choose is going to be far different than if you have a patient who is postmenopausal and is having a symptomatic fibroid uterus, right? One, you're going to do the postmenopausal patient, you would recommend hysterectomy, uh, whereas the patient who desires for future childbearing, what you would end up recommending is a myomectomy with pregnancy planning and um, management thereafter. You could also have a patient, say, is perimenopausal. The average age of menopause is 52. So say a patient is, say, 45, and she's still having periods, but she has abnormal uterine bleeding. Now, as I'll explain, your alternatives to hysterectomy invariably provide about a 5-year window between a situation where symptoms may develop again, right? But as I said, leiomyomas are estrogen responsive. So if you could temporize a patient into menopause and get them there without doing the hysterectomy, if that's their choice, then that's a strategy you can do as well. You could even throw Lupron into the mix to kind of buy yourself some more time. So this is why all of these things matter, okay? It's not just structural abnormalities, get surgery. You can do things and be creative about how you approach this in accordance with the goals of the patient. But make no mistake, the definitive treatment is hysterectomy. Okay. And if a patient, say for example, a lot of times what we see here at St. John's is that a patient, they don't follow up or care, so they'll land themselves in the emergency room with a hemoglobin of 2, which is no exaggeration. That's happened at least 5 times since I've been here, and with cases I've been involved personally. So after a while, I mean, this is a risk to their health, overall health. So to go down the road of alternatives is not really appropriate there. There, you have to recommend a definitive treatment in that case. But as any sort of doctor, especially gynecologist, especially a surgeon, you don't want to take on a paternalistic attitude either. This is always a discussion between the patient and yourself, and what you recommend and what you can do in line with standard of care and what is safe. Don't cut corners in medicine either, because if you compromise what is standard of care and appropriate in a situation, it's not good for you or the patient. Anyway, so there is a risk of recurrence. So there are a couple of alternatives to hysterectomy, and then when we discuss hysterectomy, there's a bunch of ways you can do a hysterectomy. So this is really the bulk of all you need to know in the gynecological patient, but it's very important. So endometrial ablation is a procedure where the endometrial cavity is ablated, meaning that it's the tissue is coagulated in its entirety by different methods in general for endometrial ablation, but in the Northeast, there's really only one system that's approved. It's called NovaSure. It's an FDA approved. It's a non-resect scope, meaning that it's not actually taking anything out. It is using a radio frequency electricity to perform the ablation of the endometrial cavity. Okay, so what this does is that it essentially cooks the endometrium. If the endometrium is fried, it can't bleed, right? Because the tissue is all coagulated. That's the thought. Obviously, this has to be for women who are having heavy menstrual bleeding. They cannot have a desire for future fertility because where baby implants and grows is now destroyed. And your endometrial cavity has to be normal, because if you have a cavity that is distorted with myomas like this and that, how's this thing going to fit? The way that this works is that you have, this is introduced through the vagina and through the uterus in a tube, and then you have a mechanism that engages and it makes a fan like this, okay? Then you run it for about 90 seconds. This burns the excuse me, it burns the endometrial cavity, and then it's removed, okay? Excuse me. So the satisfaction rate and amenorrhea, meaning that the periods stop and the bleeding stops, is what the outcome of this thing sort of was looked at. These were the different methods that used to be used. There was microwave energy. There was actually thermochoice, which was filled up with a balloon full of hot water, boiling water. And then that would cook the endometrium. This actually, I used this when I was an intern, but now it's been since pulled from the market. There was things like leakage of the water and burning everybody, no bueno. But so the NovaSure is what's still used. So satisfaction rate is high, 92, 93%, and the amenorrhea rate is not high though. You see, 36 to 32%. Overall, about 70. You could round that to 80% of people actually found success with it, but it's not 100%, as this will show you, at least objectively, okay? But it's certainly an option you can try if you're done with or childbearing, or you don't deserve future fertility and you want a minimally invasive technique to maybe help. This is worth it. Now, I'll tell you right off the bat, with the leiomyomas, it really depends also on how many you have and how big they are, okay? So you can't loop them all into the same group. You have to use patient selection and your clinical judgment based upon the concepts I'm presenting to you. So say if you have a patient, she has a leiomyoma and she has a bunch of little ones here, right? That actually will result in heavy menstrual bleeding and pain, right? If you do this procedure, this may help you. If you have these big, giant, bulky uterus here, and you have ones here, like this is probably not going to work, right? You could always offer things, but generally you don't want to put patients through a bunch of things that you don't think will work. There are other alternatives, okay? But this remains an alternative, especially in the well-selected patient, okay? Um, a complication of this that they may test you on, you don't see it all that often, is something called post-tubal ligation syndrome. Basically, what ends up happening is that when you do this procedure, some endometrial tissue ends up here, and then that can cycle and cause pain. It's called post-tubal ligation syndrome because it was first categorized when women, so you have your fallopian tubes, right? They would have the tubes ligated, and some of the endometrial tissue would hang out in this spot, and then it would cause cyclical pain and bleeding, okay? But that's something that can happen with this, but it's not very common. Uterine artery embolization is something that's actually becoming increasingly popular, but there are nuances to this as well. To start uterine artery embolization, it's usually, you'll hear UAE used. So it's like, oh, did they offer her UAE or she had a UAE? This is an acceptable sort of definition in our community. This is a procedure that's performed by interventional radiologists. And basically what it does is it embolizes, as it suggests, the uterine arteries by occluding them with polyvinyl alcohol particles of so they basically put these they'll put the interventional radiologist will put a catheter through the femoral artery, or there are a couple of other approaches that they can do. Usually that's popular. And they introduce these particles into the uterine artery, and it embolizes the blood supply to the uterus. Now, the thought is that, well, it's not a thought, but what it does is that it will starve our fibroid here from its blood supply, and then it'll die. This is also used in cases of postpartum hemorrhage, if you have an institution that will do it. And not to get into this because it's not the point of the lecture at all, but like the polyvinyl alcohol particles, sometimes they could use different things. Like they could use gel foam and stuff like that, because instead of totally occluding it, they can use something that will dissolve, so it only lasts a couple of days, so it's used to slow bleeding, like is the case in the case of postpartum hemorrhage. I'm not an interventional radiologist, but there's more nuances than that. But the point is that the things they put in there can vary, so it's not a total occlusion all the time. Sometimes it's just to slow it down. So it has a utility in the field of obstetrics in the realm of postpartum hemorrhages as well, in cases of serious case in more complicated cases than if you have the infrastructure. But this is the logic here. But as you can imagine, blocking this doesn't only starve the fibroid, right? It also starves the corpus itself. So that has an obvious impact on future fertility, right? While it has not been well investigated, it definitely has a potential for impacting potential fertility, and also can cause obstetrics problems, adverse obstetrical outcomes, things like intrauterine growth restriction, preterm labor, etc. Mainly just because you've damaged the uterus, right? And because there's nuances about how many fibroids are actually present in a leiomyoma, this uterus, etc., it's hard to really pin down exactly that. But if you look into the research, as I have done, it definitely could happen. If a patient has a desire for future fertility, it really behooves you to not suggest this, okay? This is a really great option for you if you have somebody who has multiple comorbidities that can't tolerate a surgical procedure, or where hormonal management increases them for risks like TVT or something. This is a really good option for them. This is just kind of a discussion that you can go over at your leisure. It's just kind of highlighting that there are adverse obstetric outcomes that an increase that have been seen in certain studies. And then this ME trial was the most recent, largest randomized trial that I could find, and it basically shows that in the first 24 hours post-operatively, they had less pain, um, significantly less pain than those who underwent hysterectomy. So when you're doing research studies, you have to understand what your treatment is being compared to say that it's better. Okay, so this was saying as compared to hysterectomy, but they had higher readmission rates than those for hysterectomies, and complications like myoma expulsion. What ends up happening is that once this thing dies, it actually can kind of just be passed by the uterus because it pushes it out. Um, the by and large is that this is an option in your selected patients. Okay, um, if you have a patient who has a bunch of smaller fibroids that you believe that impairing the blood supply will most readily kill the fibroids and not the uterus itself most efficiently, then it's a good option. If you have a patient who has many comorbid conditions that they can't tolerate surgery and they can't tolerate hormonal treatment, this is a great option. If you have a patient with big, bulky fibroids, doing a uterine artery embolization, that big fibroid may survive because it's recruited its own blood supply, and especially if there's a bunch of them, and you may just be compromising your uterus and have side effects without an actual resolution. Okay, so you have to pick your patients well, but this is certainly a, um, a good option for select patients. Okay, and those are really your main alternatives to hysterectomy. Now, what we'll discuss is, I mean, I shouldn't say alternatives to hysterectomy, alternatives to surgical management in as much as uh, physical incision of the uterus and removal of the fiber. Okay, so um, now the next step, or another alternative to hysterectomy, the most popular one is really your myomectomy. Okay, myomectomy is where you're removing your fibroids from the myometrium, and this is an option for those who desire uterine preservation. And anecdotally, I'll say that this is probably the best option, okay? Because in a myomectomy, you're identifying your fibroids and you're removing them, and you have an opportunity to remove them all and preserve your uterus, and it can heal, okay? So the goal of the myomectomy procedure is to remove, it says remove the visible and accessible, or really all of them that you can, and then you reconstruct the uterus, okay? You can imagine that if you have a uterus, excuse me, a uterus that is just completely stocked with these little fibroids, I mean, that's going to be very difficult to macerate the whole uterus and put it together, but oftentimes that's not the case. Usually you have a number of fibroids that you could identify, remove, and repair the uterus. And then you have a uterus that then is without fibroids, and that can have a lasting 5 or more years of relief. But keep in mind, they can grow back, as I mentioned. So there are many ways you can do a myomectomy. There's hysteroscopically, which you go through the uterus and remove fibroids. You can do a vaginal hysterectomy, a vaginal myomectomy, where you can remove the myomas. Uh, you can go through the vagina. It's different from a hysteroscopic, though, because usually these are ones that you can access. Um, you can access them without having to use a scope to go all the way in the cavity. You would just, usually this is for fibroids that are prolapsing or something like that. And then laparoscopic, which includes the quote unquote, this is not really a medical term, but straight stick, as in like the traditional laparoscopy, which is what I should have wrote here. And then there's your robotic assisted, which is a bit newer. Well, I'll explain. Or you can do what's called abdominal myomectomy, which is a laparotomy, okay? Which is an incision, laparotomy, which is an open incision. Okay. So I've added a bunch of videos if you want to see what these things look like. You could review them at your leisure. We're not going to do like sit here and watch videos, but just important for you to actually understand what these things look like. So when you're on your clinical modules and you see them, then you'll understand. So an abdominal myomectomy, the way that they've studied this, they went to see if you needed a second surgical procedure was their outcome after conservative therapy. Um, and here's the evidence, more or less, but it's the concept is the same as I've explained to you, but I want you more than to just believe me. I want you to understand where that recommendation comes from. I'll tell you anecdotally, this is what you see in clinical practice, but also what in the studies, it's like I've been saying, those who have had multiple leiomyomas, about more than half of them experience recurrence because the more you have, the more it's going to be more complicated. If you've had one, like a big, like say one big one, for example, you still have recurrence, but it's far less. Okay. Um, Again, this comes from the practice bulletin, and what I've been saying is that patient-specific parameters, uterine size, previous surgery, etc., is what you need to keep in mind. So, an abdominal myomectomy looks something like this. You make your incision, which for us is usually a low transverse incision. Now, when we say fan and steel incision, that that is a specific way of doing a low transverse incision. A low transverse incision just means it's low and it's um, in the transverse plane, right? A fan and steel incision has certain borders, and it has like this curved appearance, and there's specific things that are important for you. For example, you can have a Joel Cohen or a Maillard sort of incision that is up here. The fan and steel spares the rectus muscle. That's really the most important thing for you guys to understand. A Maillard or a Joel Cohen incision goes through the muscle. And usually you would do that because you had adhesions here or something like that. But just keep that terminology in the back of your mind. Really, at your stage of the game, it's not that important to know that. But it is a fact. So then you make your abdominal incision. And then you exteriorize your uterus, and then you make your incisions and remove your fibroids. But the intention is that you leave the uterus and sew it back up, okay? And here, there are a couple scheduled. In terms of, so when you talk about laparoscopic and robotic assisted myomectomies, minimally invasive surgery is helpful for mainly because of shorter operating times and things like reduced blood loss and reduced length of postoperative ileus and shorter hospital discharge, etc. That's all minimally invasive surgeries offer that benefit. So really, if you are able to perform it laparoscopically and robotic assisted, that's great. Robotic assisted surgery in GYN overall has not really shown a benefit over laparoscopic surgery, like traditional laparoscopic surgery. And even so, it definitely has advantages in terms of like surgeon comfort. I'll tell you, you have so much more dexterity and things like that. Where I did my training, we were trained on the robot as a matter of, that was part of our curriculum. So because our center was a minimally invasive center, so there was a bunch of minimally invasive surgeries and robotic surgeries we had to participate in. And it definitely has its advantages, at least anecdotally, and like in terms of things like optics and visualization and surgeon dexterity. But when it comes down to it, it doesn't really have any sort of benefit in benign disease, as opposed to traditional laparoscopy. And in cases of myomectomy, if you could perform it and do what you got to do laparoscopically, great. That's really the bottom line. the it says benign gynecological disease because so it says benign gynecologic disease because actually when you're dealing with endometrial cancer, I mean when you're dealing with gynecological cancer, endometrial cancer, right? So endometrial, that is treated by minimally invasive surgery. That's standard of care. It's not that the outcomes are better, it's just that the outcomes are the same as opposed to doing open surgery, so a laparotomy. But because you have the benefits that I mentioned with minimally invasive surgery, it's performed minimally invasive. And most cancer centers will do that robotic assisted, do the hysterectomy. However, cervical cancer, this is not a lecture about gynecologic cancer, but cervical cancer, when you get it at an early stage, can be managed surgically. Thereafter, it's managed with chemoradiation. They thought minimally invasive surgery was going to be better, but actually, it's worse. The outcomes are worse. Disease-free survival and long-term uh, uh, the death rate is worse with minimally invasive surgery versus laparotomy. So laparotomy is the way to go for the hysterectomy. I know we're talking about myomectomy, but hysterectomy, cervical cancer, you do laparotomy, right? And um, ovarian cancer, the treatment is the treatment for ovarian cancer is chemotherapy, right? That's the primary treatment for ovarian cancer. But you could do surgery. You could do a debulking surgery to reduce the tumor burden, and that you could do whatever way you want, whatever's feasible. Some people do debulkings robotically. Some people find that difficult, and they do it uh, laparotomy. It doesn't matter. Okay, so just to mention this, because I'm not going to give you a specific talk on gynecologic cancer, is endometrial cancer is treated primarily surgically. You could do it minimally invasive. Cervical cancer really is chemoradiation. If you get it at an early stage, you can do surgery. If it's below a stage 1B1, a 1B1 or less, but it's abdominal surgery, so laparotomy, not minimally invasive. Minimally invasive actually causes a worse outcome. And then ovarian cancer, the treatment is chemoradiation. I mean, it's chemotherapy, but you could do surgery in the form of debulking, and that can be done either way. Okay, so anyway, we're done talking about that. The point is that there's no benefit. You could do either way. So with laparoscopy, usually there's 4 ports. And then robotic, there's actually a couple more because that's just how it is, just so you know about that, because we don't do robotic surgery here. For me, I'll usually, instead of this one here, I'll do an entry in what's called Palmer's point, which is in the left upper quadrant because it's a safe space to enter, but the point is there's 4, and then robotic has a bit more because you have a couple of different things that the robot needs. In terms of methods of myomectomy, your hysteroscopic myomectomy can be performed if you have submucous fibroids only, okay? Type 1 and type 0. And usually there's a success rate of 65 to 100%, which is great because if you have primarily submucous leiomyomas and they're only within the cavity, as I've shown you, then you don't have to do any sort of incision. You just go through the uterus and you use some sort of resectoscope to perform the surgery. This is a laparoscopic myomectomy video. You can watch that. This is a robotic-assisted myomectomy. This kind of goes you through the whole process. And the reason why I've given you this video here is because robotic-assisted surgery is a process, okay? It's not just the surgery itself. The surgeon, it's very easy for the surgeon to do the thing, but there's a lot of setup. There's a team that's required. There's a whole lot that goes into it. Very cool stuff, but also to understand what the process involves is something to kind of give you an idea. And because this is not a robotic center, you may not see that. And I have nothing but good things to say about robotic surgery. Don't get me wrong. I love to do it, and I think it's great. And I think in a good center, it should be used. But just know about it, okay? Um, and then this actually is the hysteroscopic myomectomy. I will show you quickly. Okay, so the theory is that you have an instrument that looks more or less like that and resects out the thing. So this is what it looks like. This is the fibroid here, and this is a hysteroscopic view. You essentially take this instrument and you sit there and chop it up. And you sit there until the whole thing is gone. And it's actually very elegant because it can get rid of the whole thing and then you're done. Okay. If you have a patient who has only your cavitary fibroids, you could watch that video at your leisure, but this is what I was talking about. Okay. In terms of hysterectomy, the conversation's pretty self-explanatory. We're talking about benign causes because endometrial cancer is different. This is more or less what we've already said. Your vaginal and your laparoscopic approaches are considered minimally invasive, and therefore they have those immediate benefits. If you can do a minimally invasive case, ACOG recommends it, and more than that, if you can do a vaginal hysterectomy, that's the most ideal one because there's no incisions apart from what you do at the vagina. Okay, so their recovery is excellent. Vaginal hysterectomies are a standard of care when you have any sort of prolapse. Okay, and that's usually why you would choose this. In terms of hysterectomy, it's definitive treatment. As I mentioned, it's one of the most frequently performed surgical procedure in the United States, and the most frequent indication is leiomyomas. And this is why we mention it. Okay, here's a video of vaginal hysterectomy. You just got to sign into YouTube and, say that you're not a preteen. I was hoping that wouldn't come up here. This is an example of a laparoscopic hysterectomy. And then this is an example of a robotic hysterectomy, all of which I guess are telling you it's age restricted. But you could log in and you should have access to it. Okay, I went through it myself. This is just to mention, we mentioned in our prior lecture about placenta accreta spectrum, right? When you have a placenta that invades farther than the decidua. And the treatment I told you is cesarean hysterectomy. This is a talk about hysterectomy, so I thought I would mention it. It's just a video showing you how that's performed. Okay. And this is analogous to a total abdominal hysterectomy. So now we're going to talk about ovulatory dysfunction, okay? And this is the last half of this talk. So you have this thing that's being recorded. So I would encourage you, stop and pause it, take notes, look up what you have to do, and review this very thoroughly, okay? Because this is really the bulk of GYN, as I mentioned. We're going to talk about ovulatory dysfunction now, and I've already kind of alluded to things like the interplay between unopposed estrogen in the menstrual cycle and its effect on the endometrium. This is the whole pathogenesis for ovulatory dysfunction. And understanding that will help you immensely on all of your questions, on anything you see in clinic. Anything you see on your clinical modules. And if you want to enter the field of obstetrics and gynecology, if you understand this lecture very well, that's like the bulk of what you're going to do. So, and while it's foundational, most foundational things are best understood as the building blocks for your future work. So, let's just get into it. As I mentioned, abnormal uterine bleeding associated with ovulatory dysfunction is primarily due to the ovaries, okay? The ovaries and the endocrine system. I say the ovaries because the ovaries are the one that is going to lead to the production of these hormones, okay? That is not to understate the fact that the hypothalamic pituitary ovarian axis is where the abnormalities lie. So the end of this axis this road is the ovary, but the pituitary and the hypothalamus play a role, okay? And that leads to the interruption in the ovulation cycle. The abnormal uterine bleeding occurs, as I mentioned, because in the setting of unopposed estrogen on the endometrium and chronic unopposed estrogen, okay? Um, so reasons why you may have ovulatory dysfunction are both physiologic and pathologic. So to have structural abnormalities of the uterus is never physiologic, right? If you have a structural abnormality, that's a problem. With ovulatory dysfunction and bleeding because of it, sometimes you can have a physiologic problem, mainly based upon your menopausal status, your menstrual status, and then also lactation kind of interrupts it a bit. Okay. When you're breastfeeding and you're lactating, you have prolactin in the mix. And even when you have hyperprolactinemia, it can cause a disruption of this cycle. So, but this is physiological, right? But adolescence is something important to mention. We don't really see a whole lot of adolescent GYN patients here. And to be honest with you, you don't really see them overall. It's not very common. Where you'll see an adolescent patient in the GYN context is usually, say, a child who has had some sort of straddle injury off a bike, and then they develop a vulvar hematoma. So they need a GYN evaluation to make sure it's not expanding. Mullerian abnormalities, like you have just developmental problems of the uterus itself, which can cause some bleeding, and like also things like imperforant hymen or persistent stuff like that cause obstruction and pain in someone. But on the whole, you don't really see problems. But you want to think of the very young patient like the postmenopausal patient, because these patients don't have estrogen, right? Because their ovaries are not turned on yet. But you can still have consequences of abnormal uterine bleeding. It's not really uterine bleeding. It's really kind of like atrophic vaginitis because it's atrophy, right? Because they don't have estrogen stimulation. So sometimes you could have bleeding because of that. So, but this is kind of obvious, right? If you're dealing with a very young patient, that's on your radar. If you're having irregular periods that develop, a woman comes to you, she's like, I've had regular periods, but now like my periods are lighter and then I'm having spotting in between periods. Well, you may be entering menopause, okay? Especially if you're in your late 40s, that's something you want to suspect. Though sometimes you have something called premature ovarian failure, where someone in their 30s will present with this. And then what you can do is actually order a test called anti-Mullerian hormone, AMH. And that'll actually tell you your ovarian reserve. We like to use this test in the context of working up a patient for infertility, but also it could be used in this context. And sometimes you'll see a patient goes into premature ovarian failure, right? Obviously, pregnancy. If a patient comes to you and she says, "I'm not having a period already," she's like, you say, "Is there a possibility you could be pregnant?" She says, "No, no way." Do a pregnancy test. Sometimes it comes back positive, right? Any amenorrhea visit, no periods, you got to do a pregnancy test. Don't forget that. On your questions, they'll say that. Give you a question stem. They'll say, what's the next step? Amenorrhea, pregnancy test is your next step. Okay? If that's not an option, well, it's asking for something else. But that is 100%. So barring physiological reasons, then you have to find out why your HPO axis is disrupted. You could have PCOS, which has very specific criteria. PCOS follows your you have ovulatory dysfunction, so oligo or amenorrhea. Oligomenorrhea meaning a reduced period, and then of course polycystic ovaries. It's like 10 or more, I believe. And that's how you would diagnose that, but that can give you ovulatory dysfunction. So I had a patient recently who had this complaint. She's in her 30s, and it's funny, I had two patients on the same day who presented with the same complaint who ended up with PCOS, but one of them had all the things. Like she had the hair growth, she had amenorrhea develop, which is secondary amenorrhea, remember, because secondary amenorrhea means that you've had a period at some point. Primary amenorrhea, meaning you've never had a period at all, that's when you're thinking about like genetic disorders and stuff like that. And There's a whole lot of fun things you have to memorize for your exams and things. Even I have to do that, but there's no other way but to memorize it. But so secondary amenorrhea, right? So she had that. She had hair growth, and then I did a transvaginal sonogram in the office, and you see an ovary, right? And you have all these little follicles. They call it the string of pearl sign, and that's what it looks like, just like that, right? So I had another patient who didn't have the virilization, but she had the polycystic ovaries when I did the sonogram, and she had the amenorrhea, so that also counts. The management of this is a separate talk, but the point is that it's pathologic, and it can cause this. You could also have androgen-producing tumors and congenital adrenal hyperplasia, and there's an algorithm to understand how to diagnose those. Those are rarer, but you do see them. The bottom line is that you do some sort of stimulation test, like ACTH stimulation, and if there's a problem, uh, with, say, congenital adrenal hyperplasia and some other sort of intrinsic problem, uh, ACTH will make a difference at the hypothalamus, for lack of a more sophisticated explanation. If you have a tumor, you could give as much ACTH as you want. It doesn't matter because the tumor is doing its own thing. It's in the adrenal, and it's just whatever you do, it won't respond. That's kind of a quick way to understand that, but very nuanced. Uh, So that's like your hyperandrogenic cause of anovulation. Hypothalamic, meaning that there's a problem at the hypothalamus. Things like the female athlete triad can cause that. Anorexia can cause it, and what it's causing is the period really to stop. That's really the biggest thing. It's not that you're having more bleeding. When you have hypothalamic dysfunction, it's that the period is stopping. The female athlete triad is the period will stop, and also anorexia nervosa. It's the same sort of thing. Like your increased exercise, your reduced intake, it impacts the hypothalamus. So this is mainly a history-driven thing, right? You could do some labs to find this out, but I mean, you're not going to miss anorexia, right? By the way it looks, and also the social history. That's a history-driven thing. And then you do your lab work, as I mentioned, hyperprolactinemia, thyroid disease, pituitary disease, premature ovarian failure. That's AMH is the lab that may not be obvious. So you draw your endocrine panel and you see hypothyroidism will give you periods that are infrequent and you have spotting. Hyperthyroidism will increase your bleeding, and that's easy to remember because the lower end will stop, the higher end will go. And then prolactinemia, then if you have hyperprolactinemia, well, you got to make sure you're not lactating, but your level won't be that high even if you are. And then you have to do your MRI because you have to see if you have an adenoma in the brain, a pituitary adenoma, okay? And that is actually the next step. And we oftentimes do order that as the GYN. Premature ovarian failure, as I mentioned, and there's really not a whole lot of things to do with that. If premature ovarian failure, you'll also suspect if you're having like menopausal symptoms, okay? And the primary pituitary diseases, what you'll do is you'll draw hormones like FSH, LH, etc. on day 2 of the menstrual cycle, but usually they won't know this. But the pituitary disease, you evaluate things like FSH, LH, estrogen, etc. Then obviously, if you are on certain medicines, you want to make sure that that's not a malingering association, like especially psychiatric meds, like antipsychotics can cause that, etc. So we mentioned the menstrual cycle. This is a very high yield thing that you have to understand. So here's a diagram. This is showing what the ovary is doing. This is your basal body temperature. The anterior pituitary hormones are here, LH and FSH. Your ovarian hormones, estrogen and progesterone. What the uterus is doing here. And then also I just mentioned that inhibin B and inhibin A are also part of the mix, right? This part here is the actual menstruation itself when the lining is sloughed, okay? So your first phase is your proliferative phase because your lining is growing, so it's proliferating. And then the second is the secretory phase because that's where you're basically secreting your progesterone. And if you're pregnant, this continues. Inhibin B and A are here too. Inhibin A is the one that is in your genetic screening in your obstetrical patients. Inhibin B, do we know what inhibin B is found in? Inhibin B is secreted by granulosa cell tumors. Okay? Granulosa cell tumors. Granulosa cell tumors. This is a marker here. Okay? I remember I got questions on my exams, my shelf exam, about what phase inhibin B peaks in. So the proliferative phase here, estrogen increases, right? So I told you, unopposed estrogen. Unopposed, what's opposing estrogen? Well, it's opposed by progesterone. This balance is what maintains your endometrial lining, okay? So in the proliferative phase, which is between 0 to 14 days, 14 days is where your ovulation occurs and your LH surge, so LH bumps, right? That's 14 days, and you could see from day 14, you go up, you'll see the egg being released in this image here. Estrogen increases. Estrogen will increase the lining of the uterus, okay? But this increase is only sustained in the secretory phase by progesterone. So if you have estrogen that's unopposed by progesterone, it increases, it increases, it increases, it increases. And you have estrone in the periphery because you're morbidly obese, and you have a problem with your HPO axis where you don't have this balance. This will continue to grow and grow and grow, but the progesterone is what maintains the blood vessels to sustain it. Okay, so if you keep growing something, it's like a tumor that expands. Eventually, it'll just slough and necrose. So that is why you have your bleeding in the first place. You have that bleeding in the first place because you have unopposed estrogen that keeps growing and you don't have a progesterone balance to maintain it. So this is why you can treat ovulatory dysfunction with hormones in the first place because you reestablish that balance between estrogen and progesterone. Postmenopausal patients who have a thickened endometrium, meaning that this tissue is thickened, it's concerning because they shouldn't have estrogen being built up to make this thick in the first place, okay? If the estrogen is being produced, there's a reason why, and that reason, a reason why that can happen is because of endometrial cancer. So this is why it makes sense. This is why unopposed estrogen makes a difference. It increases the lining of the uterus, that's what it does, but it should be balanced with progesterone in order to sustain itself. And by virtue of the principle, when progesterone falls off in the non-pregnant patient, the patient has menses, the lining can't sustain itself. So it sloughs, and that's where the bleeding comes from. And then the cycle continues. But if you just have this keep going up, you're going to have the lining build, 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 build. It's going to slough, but then it's going to continue to build. And so you're going to just have this constant bleeding that happens that's unpredictable and bothersome. And then in some cases can lead to acute blood loss and symptoms. Okay? Throw that into the mix with fibroids pre-existing, which both of them can happen, then you have a problem. And this is why hysterectomy is still a mainstay for treatment of these disorders. Understand this very well. If you have questions, reach out to me. But understanding this physiology is important for questions that you might ask, but this is why the treatments work. This is why we can give progesterone to patients that have ovulatory dysfunction, and it helps them because it reestablishes this balance. So to understand, before we get into the treatments of ovulatory dysfunction, which is really just hormonal management, you could base your differentials on abnormal uterine bleeding based upon the patient's age. And that's not just a test-taking strategy. This is something you also see clinically. So it can help in both ways. So for 13 to 18-year-olds, abnormal uterine bleeding is most frequently associated for persistent anovulation. Remember, structural disorders are responsive to estrogen. If you're having this age group, you haven't had estrogen on board long enough to really cause things like polyps and fibroids to grow. So this is the age group where you're thinking of persistent anovulation due to what I said, but also this is when the age that women are starting to use hormonal contraceptives. So sometimes that can cause abnormal bleeding and cycling. They can be pregnant, which is something you always need to rule out. STDs happen as a result of early sexual activity, and maybe because it's so early, precautions aren't being taken, but these are possibilities is the bottom line. While coagulopathies and tumors are a possibility, far less. Okay, if an adolescent requires hospitalization for when they start their periods, that's when you want to suggest for abnormal uterine bleeding, I should say. That's when you want to think about a coagulopathy because like I said, they haven't had the structural abnormalities to cause this yet. And usually the most common one is von Willebrand's disease. You'll order your risdiplam assay, and that'll tell you. Keep in mind that the result, sometimes your results will say an increased activity. That's nothing. It's a decreased activity is your problem, okay? This is also associated with factor 8. So actually the treatment uh, in von Willebrand's disease, in addition to other things, is also desmopressin because it will force the release of factor 8 and von Willebrand factor. But you could discuss this more with a hematologist, but just as an FYI. Uh, this is what we just said. So 19 to 39 is when you want to think more of your structural lesions come into play. Okay, PCOS is also something that comes as a problem. Your secondary amenorrhea here, because you're past this point where you would have already understood what your menstrual pattern is at 13 to 18. So this is where this is, and then hormonal contraception and pregnancy are always on the table in addition to STDs. Endometrial hyperplasia and cancer, while a possibility, is far less likely in this group. If you do a residency and when you're on the cancer service, you'll see a lot of things, but by and large, this is less of a concern. 40 years to menopause, and ovulatory bleeding happens again, like when you were in your prepubescent period, but this is because of declining ovarian function, and it's normal. Endometrial hyperplasia and carcinoma comes into the mix. When patients have endometrial hyperplasia or carcinoma at age older than 45, it's worse. So it's definitely a factor of age. And then leiomyomas, of course, are on the thing. But the most common cause of bleeding for a menopausal patient is what? It's atrophic vaginitis, right? It's atrophic bleeding. So just keep that in mind. If a patient is postmenopausal, you need an endometrial biopsy to rule out endometrial hyperplasia or carcinoma. Okay. As a matter of routine in hospitals, if a patient is being booked for a hysterectomy, they require some sort of endometrial sampling just to rule this out. It doesn't matter what age they are. They're getting a hysterectomy, they need that. Okay. And that's just because the treatment for endometrial carcinoma is different than benign disease, even though it's some sort of hysterectomy, right? This is a flow chart to review the possible steps, but really the bottom line is the same, and this is all what I've described. Some people like pictures better, so you can see it this way. In terms of management, medical therapy is limited to progesterone only therapy or combined hormonal contraception, meaning estrogen and progesterone. So progestin-only therapies are many. The levonorgestrel IUD, like I mentioned, there's progesterone and migestrol. These are and northinidrone. These are all just oral forms of progesterone. Okay, and progesterone comes in different formulations and it has different tasks. A lot of times you'll have someone on megestrol, which is Megace. You'll see it in the geriatric population because that's an appetite stimulant. This is why patients who take progesterone-only medications say they gain weight. It doesn't cause them to gain weight. It increases their appetite, and that increases your calories, and that increases your weight. Right? The reason is here or there. It's something that happens. So it's something you need to counsel your patients about. Okay. Um, Depo medroxyprogesterone acetate, you might hear a woman get her Depo shot. This is an IM injection that lasts for 3 months, usually in the context of contraception. Okay. But they all have the same effects because they're all, in their essence, progesterone. The IUD can work locally, and that could last for around 5 years. So that's preferable for things like if you have bleeding disorders and also you want contraception, right? These are oral forms because people sometimes don't want a shot and sometimes don't want something put into their uterus, okay? Um, there's a lot of it. There's a great deal of interaction between combined hormonal contraception with estrogen and progesterone, in addition to other medicines. So there's something that the CDC has created that is called the U.S. Medical Eligibility Criteria for Contraceptive Use. There's an app and everything else. It's a very extensive document, not worth memorizing, but just for you in practical application. That's a resource that you could do to make sure that before prescribing these medicines that you can actually use them, especially in complicated patients. So in terms of these only progesterone only formularies and the methods to which I mean the delivery methods, there's also patches, there's rings, in addition to oral. Vaginal rings is an insert you put into the vagina. It works just like the other like oral contraceptive in that you take it for 3 weeks, and then your week where you would have a period, you remove it. It's the same thing. The overall benefit is what I mentioned to you before. It thins the endometrium and protects it from hyperplastic transition. And if you already have an ongoing imbalance here with unopposed estrogen, the addition of progesterone will help that balance. Okay. And the combined medicine will maintain this balance. So you may hear of different phasic medicines. You can review this because it's not a terribly important conversation, but just know that when it's at oral contraceptive pills, it involves ethinyl estradiol, right? Which is the shorthand is EE. So that's estradiol, right? You could have estrone, which is one, estradiol, which is what the ovary makes, right? So you have estrone, which is E, and that's in the periphery, right? As I mentioned, periphery. It's peripheral, right? Estrogen, estradiol is what the ovary makes. And what about estriol? Do you know where you see this? Do you remember? In OB, they'll look at estriol on the genetic screen, right? The quad screen. Estriol, because that's involved in mechanisms like the placenta, that will involve like the interplay that to assessate for fetal genetics. Okay, that's where you see estriol. So estrone, estradiol, but here estradiol is what we're dealing with. Estradiol, and it's going to be estradiol plus some sort of progesterone. Okay. Okay, so here, like the so a monophasic just gives you it's the same amount of estrogen and progesterone for each pill. But what um, the thought is
clear this.
Is that well? Some women with side effects to certain medicines or contraceptive medicine, like it's not. This doesn't work that way, right? It's not like you have one dose of estrogen and progesterone the whole time, and then you stop. That's what monophasics do. They give you one dose the whole time. So people thought, well, sorry, maybe we should make it more mimic the menstrual cycle a bit more more appropriately, and that will have a better side effect profile, and that'll also make a patient have the best sort of coverage and functioning. So someone did a biphasic. All right, so then they'll be doing two doses, and then they said, well, a triphasic is actually probably more appropriate, and then there more recently as something where it's four hormone doses, where they try to really get it to be the really mimic how your body's menstrual cycle functions. The bottom line is that they're all pretty much the same, right? If you speak to the family planning fellows and specialists who actually are the ones who know about this subject the most, they'll tell you it doesn't make a clinical difference, okay? Um, Anecdotally, a patient, usually you'll start them on something that has a lower dose of estrogen and progesterone, and you see how it goes. I usually will give a patient this one, low estrogen. Okay, that's like, I think it's, and I'll give them like a 1.5 um, of the ethinyl estradiol, and I forget what the progesterone is, but you start with this and you see how it goes. Okay. Um, that being said, the evidence for why this makes a difference in terms of helping with ovulatory dysfunction, the big randomized trial that is used is using a triphasic with orthotricycline. So, and there's actually no other studies that are looking at these other ones, right? Not to help with placebo, right? These are the ones kind of study it in a different context. So really, if you want to use the one that's the standard, you would use a triphasic orthotricycline. And then levonorgestrel IUD does help as well, as I mentioned. So the treatment for 13 to 18, you want to try to use combined hormonal contraceptives, and that's a mainstay of therapy. 1939, the IUD comes more into play here because that's helpful long term. And then 40 to menopause, same thing with the IUD essentially. Okay. Um, and also there's more of a benefit towards progestins because that offers a better advantage of endometrial protection. Because if you're concerned about things like unopposed estrogen in the context of menopausal development and things like that, it helps. So that's kind of more, you may lean more towards that in 40 plus, okay? If you have acute uterine bleeding that renders a patient hemodynamically unstable and they get admitted to the hospital, the way that you treat that actually can include high dose estrogen. And sometimes that comes up on your tests. And then you're like, well, why are you giving high dose estrogen, right? Isn't that going to make the problem worse if you're having heavy bleeding? Why would I give them, and it'll say like IV conjugated equine estrogen. It'll be like, that sounds like it's not, that's going to be worse. But actually, it isn't. It's actually a very effective therapy if you've ever, you don't do it a lot because if you give IV estrogen, you're worried about precipitating thrombosis. But what you end up doing is this, if you take it on the menstrual cycle, you have a shot of estrogen, right? That builds this lining up. So that's how it gets, so that helps with a situation because if you're bleeding, you're in this sort of sloughing phase, right? So it's almost like you're here. So then if I give you your IV estrogen, it very quickly brings you here into this step on the diagram. So if you're in your menstrual cycle and this is sloughing, the estrogen will build you up quick, so it'll stop the bleeding. But you can't give it for too long because then you're going to have the same problem where then you build up your lining and then the lining is building and building and building and it can't sustain itself. So in the acute period, that's how you can manage bleeding. That's actually one of the most effective ways, but you have to worry about clots and stuff like that as well. That's actually more of a it's a more difficult clinical scenario, so they're not really going to ask you questions about that that are going to be too challenging. But if you have a patient and she's having acute bleeding and she's unstable in the hospital, you give IV estrogen unless you have a contraindication. And really, the contraindications are there anything for estrogen and clotting, like say migraines with aura or any sort of contraindication if she's a smoker, etc. This is a really long lecture, but and ordinarily in the past I'd broken it up into different sections on different days, but because it's recorded, well, you could just follow it at your leisure. So the last part we're going to talk about specifically is endometrial hyperplasia. I've really kind of mentioned this a bunch of times, but hyperplasia is increase in the number of cells, right? That's hyperplasia on the whole. That's different than hypertrophy, which is just the cells grow bigger, right? Because when you have in your pregnant uterus, you have both. But the hyperplasia is the growth of many cells. So this is why if you have on a pelvic ultrasound, you have a thickened endometrium in a postmenopausal patient, you're worried about endometrial hyperplasia because why are you having a thickened endometrium? You're not menstrual, so you shouldn't have an endometrium that is built up because of your menstrual cycle. You may be on hormone replacement and things like that, in which case if you're on, say, tamoxifen, then you may have a thickened endometrium and you may have endometrial polyps and even bleeding, and that's not terribly problematic because But if you otherwise, that's a concern. So at the get, endometrial hyperplasia is just a development is a growth of more cells. You could have non-neoplastic entities and precancerous entities, okay? And then endometrial glands, their size and shape also, that is referred to as a tibia, and that also is part of it. So endometrial hyperplasia invariably happens because of chronic estrogen stimulation unopposed by balancing of progesterone, as I've really mentioned ad nauseum, okay? There are two classification systems that you may see, and for you, it's not terribly important to know the nuances of this apart from knowing what they are. So the World Health Organization system, which is kind of the most widely used, is you have your normal endometrium, which if you have an endometrial biopsy, say, it'll tell you either if you have a proliferative endometrium in the beginning phase or a secretory one in the later phase of the menstrual cycle, as I mentioned. That's how the pathology will be described. It'll say secretory endometrium, okay? You're good. That's normal. You could have simple or complex hyperplasia, okay, and that's just based upon the degree of how hyperplastic it is. But that is not even really what a classification is. So it'll mention if you have hyperplasia, okay? And then really atypia is the thing you're concerned about for carcinoma. It's nuclear enlargement. The nucleus shouldn't be enlarged, right? Because that means that it's working hard to do something. And if it's working hard to grow and it shouldn't, then that means that neoplasia is a possibility. And the hallmark of neoplasia is really crowding based upon these atypical cells, okay? So if you have complex atypical hyperplasia, That's something that's concerning for carcinoma, and it's about maybe 40% of those cases actually do have a carcinoma associated with them. Uh, your endometrial, if you're using this classification, the EIN, which is endometrial intraepithelial neoplasia, similar to how cervical cancer is managed, really, uh, it it's just two things. It's either benign or you have the intraepithelial neoplasia, which is your precancerous change. Okay. Gyne-oncs like to use this, gynecological pathologists, but really it's not that common, and I don't think it'll show up on your exam, but things are changing, so that may be. Um, the bottom line is that if you have benign, you're benign. If you have EIN, well, that's a precancer lesion, okay? Um, they studied this, ACOG and the Society of Gyne-oncs, to see which was more reliable. They are found to be similar. So just know what they are. This is just a pretty good picture to show about the nuances of these things, but I don't want you to memorize this at all. It's just a way to visually understand it in all that we've explained. So go through this, and if you have any questions, we could review it, but it's very comprehensive, and really these concepts are what you need to know in regards to abnormal uterine bleeding. And that's the bulk of your gynecological um, questions, clinical scenarios, and really all that you will see in your clinical modules if you have a good understanding of this. So I hope this was helpful, and I'll see you next time.